Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And I'm Mark. Okay, so following up from the previous episode, we talked about identifying and measuring impairments, getting an understanding of which impairments are relative, and how we would go about reassessing them. In today's episode, we're going to talk about treatment. What we what are our go-to methods, or what we use to address these impairments to get good outcomes. So yeah, go ahead.
Let's talk about like where we kind of left off the last episode, where we found off like a bunch of different impairments. We got our baselines and stuff like that. I think one of the things that kind of gets lost a lot of times is where do we go from there when we have our baselines and all our list of problems? Where or how do we synthesize that information to better help troubleshoot our patients and figure out what the root cause is? So, like, Mark, what do you typically do once you've gotten your baselines? How do you go about determining like what is their primary issue?
Yeah. So I don't know. I think I'm gonna have to turn this around a little bit. Like, I guess it depends. Like, when you say issue, what do you mean? What do you mean by issue? You talking about anatomically? You talking about like structurally? Like, what? When you say issue, what do you mean?
I guess I mean by like their movement impairment diagnosis. Like, what is the big thing that you kind of chunk their issue under
Okay.
as like
Gotcha.
what you need to work on?
Yeah. So I guess, at least in my practice, my first go-to method to attempt to address these impairments is going to be from a repeated movement standpoint. So I'm starting there, regardless of if it's the body part, the kind of pain. It's something that I find can benefit a lot of patients, a lot of different presentations. So that's typically my first stage in managing someone that's coming to me. You know, not that it's kind of like forced upon people, but essentially in the way I'm trying to do things, it's my first step. If it's something that works, if I'm getting a positive response, if I'm reassessing these impairments and they're continuing to improve with repeated movements, then that's where I'm probably going to stay until I've exhausted that. If, let's say it's been a session or two and I'm not getting the desired response out of repeated movements, I find that they are beginning to kind of fall out of that category, or we've exhausted the planes of movements the planes of movements and the type of movements I feel like they would have responded to. I'm typically going more of a route where I'm looking to, let's just say, well, we can talk about this term more, but we can say I'm trying to recondition that area, that body part, whether it's like the joint, muscles, stuff like that. Just start to teach that area of the body that to handle load a little bit better. And kind of going in line with that, instead of trying to, and maybe even in some cases I may do this before looking at the kind of exposure type route or reconditioning route. I may look to change their symptomatic response from a control or movement standpoint that doesn't utilize repeated movements. So, I could just, to give you a single example, I remember this person coming in that had lower extremity pain, most likely coming from their spine. We did all kinds of spinal repeated movements, nothing changed. Had them do a couple bridges and their toe numbness went away, right? So, firstly, I'm looking at repeated movements. Secondarily, I'm looking at other types of movements, maybe not necessarily like repeated, that may have an influence on their symptoms. And then along with that, if I can't make a quick change in their symptoms, it may be a medium or long term thing where I'm looking at like a reconditioning exposure standpoint to help the person with their impairments. And what do you look at? Do you look at a certain thing first? Do you have a different kind of approach that you would use?
So, when I'm troubleshooting for an eval, I typically will, like we talked about previously, gather baselines, find out what your comparable signs are, and then kind of create that list of impairments and deficits, right? And
Yeah.
then after that, I definitely go right to the joint. Like if I address it through repeated motions, I notice that that is such a quick and easy way to create change. And it's so fast, and the changes that you make are just can be so profound, that to me it just makes sense as your first line
Yeah.
of defense.
Easy to do, like you
Um,
said, big change. Patient can notice it, right? It's easily reproducible and manageable by the patient as well. Okay, so that's your first step. Where are you going? Where are you going next?
Yeah, so I think like the overarching theme for what I'm looking to do when I am like troubleshooting a patient on eval, or like when I'm reassessing them, I should say, is a lot of it is just pain modulation. Can we change their symptoms in any way, shape, or form? I think that is such a powerful tool. And so I'll typically look to do that either through repeated motions. If that doesn't do the trick, then depending on the body part, I may look to go to restoring their range of motion better. And usually, repeated motions does that already. It just does it in a really odd way. It tends to do it in
Yeah,
a
yeah.
backwards way than what you might expect, where they're having issues with bending their knee, and then we end up straightening it, and then the knee ends up bending further. It's really odd in how it works, but if
It
it works,
works.
it
Yeah, yeah,
works.
it's there. Right. Like that's why I was asking, like you said, when you're talking about the issue, I was like, are we talking structurally, talking anatomically? Because like when we're talking from a and this is maybe applicable for many different kind of interventions, but at least for our first step when we're talking about repeated movements, it doesn't necessarily matter what's happening structurally. If we're able to test retest, if we're getting um a a better response in regards to person's symptoms, their range of motion, any kind of functional limitation, yeah, we're just going to go with it, and we're going to use our test retest to continually assess if we're getting continued improvement, right?
For sure, for sure. I think that the next thing that I'll typically go to, like I said, is I'll look at the joint first. So if that doesn't work, then I'll look at the actual like joint mobility and range. And if I can start to range them, and then that decreases their issues, so I'm able to restore some of that function, and it decreases their pain. That's awesome. That's so fast and so easy for us to kind of determine. But the other part is when we do that, that's when we can start to tease out a little bit more. Is it the joint that's restricting them, or is it a like an issue with their soft tissue? Is that something that needs to come into play? And then just doing those things helps me be able to tease that out a little bit better between the structures of what really needs that attention. And the next thing that usually ties into for me is their quality of their motion. And you guys have heard Mark and I talk about like the quality of the motion. What we usually mean by that is like their motor control and how they're moving, how they're recruiting things, perhaps like the sequencing of how they're doing certain movements. And if I can make changes in regards to their symptoms by improving their quality, that definitely gives me a lot more insight as to what exactly is going on. Maybe they have like some tissue restrictions or joint restrictions, but that could definitely be a secondary cause. It's not the primary one. Maybe those deficits are popping up now because their motor control was never addressed. And that's why we're running into some of these issues going on down the road. So that's where I feel like identifying the primary impairment is so important, because you don't want to just be chasing symptoms and treating symptoms when you haven't actually treated the root cause. It's nice, you can help make an impact, but if it doesn't have significant carryover, such as like a significant reduction of their pain for a longer period of time, it really doesn't matter much. If you do manuals and they're like, oh, I feel better, and then 5 minutes it comes back, well,
Yeah.
did it really get better?
Yeah, right, yeah. So you're looking at, I mean, you talked about a couple different aspects there, repeated movements and the motor control. It talked about joint mobility, maybe soft tissue, mobility restrictions, stuff like that. But when it comes down to it, the intervention you're applying, you're looking for a long-lasting, significant change in their impairment.
Oh,
The impairment that you're
for
addressing.
sure.
Yeah. Okay.
Yeah, I think that is something that definitely gives you a lot more information. Like before, if it got better, I'd be, oh, cool, it got better. And then I wouldn't even think about the time frame that it lasted for. So now, to me, I think, okay, if I apply this intervention and they get better for 5 minutes, and then I reapply it and it stays the same,
Yeah.
and it only gets better for 5 minutes, is it doing much? Versus, okay, it got better for 5 minutes this time, the next time it gets better for 30 minutes, and then the next time it's for a few hours. That to me is definitely telling me that I'm going down the right path. So I tend to use those like indicators a little bit more to help guide my treatment of whether or not I'm working on the appropriate deficit at this point.
Yeah, I think that's a good point you're making too, because I don't know if we've stated this explicitly. We've talked about test retest. We've talked about measuring impairments. We talked about we're talking about treatment and measuring the amount of reduction. And when we're talking about test retest, when we're talking about things being better and remaining better afterwards, we're talking about a significant change in the symptoms, noticeable, or impairment, notice that which is noticeable by the clinician and the patient, which lasts, right? I don't know. I mean, yeah, like, we can maybe in some presentations, like lasting for a couple minutes is good. It's something you can work with. But we're talking about symptomatic change that is, 20, 30 minutes, an hour, right? Something that we're working to build towards, not just something where you have someone do an exercise and, it's better for a couple minutes, but then you apply it again and it doesn't change at all, right? And then you have an inconsistent variable effect. We're talking about interventions that are working consistently and providing the desired response on a consistent basis. And that's kind of what, regardless of the treatment, it's kind of what we're looking for, right?
Yeah, I think one of the things that is really interesting there is like two things. When you apply a treatment and you get inconsistent results with the patient, that is already telling me that you're probably not fully on correct in regards to what your intervention is.
Sure.
Either it's like completely wrong and you need to pivot, or it's just that you haven't hit the nail on the head yet, and it just needs some work. You got to find something that is more tailored to what the issue is. But the second thing that I've realized is a lot of the interventions that people can give are meant to create that change, but whether or not it's long lasting is a different story. For example, if you use a manual skill, if you give like a grade 5 mobilization or manipulation, the biggest thing is you just gave a huge input into their central nervous system. That's going to create some sort of change. You're going to desensitize them. The same thing goes for if you use like Graston or soft tissue work. That's going to create an analgesic effect in the short term, but does it actually do anything long term wise? And this is coming from someone who actually uses those interventions. It's something that I have to always keep myself in check with. Like, is it actually working? Is it something that maybe the patient just perceives as being valuable, or is it actually addressing the root cause of their deficits?
So contextualizing it so it's appropriate for that patient at that time, and is it giving you the desired result, right? Because we could, it's if you have someone coming in, let's just say low to mid grade symptoms, it's probably, if they're should I put it? They may respond or have a transient reduction in symptoms to many different kinds of interventions. Being able to tease out what is going to provide them the lasting reduction in symptoms and what they're going to be able to reliably reproduce on their own is a whole different story.
Very, very true. Yeah, I couldn't agree more with that. Like so many things that we do can, like we said, can make an impact on how they feel in that moment. It doesn't necessarily mean that we fix their problem. That's where it's so important to consistently check in with your patients, doing the test retest method that we talked about before, and just making sure, are we making progress? Like when they go home, actually make sure that they're doing the things that provoke their symptoms. Going home, and if that task isn't problematic anymore, trying more things, doing more things, and seeing if their function is actually improving, and if there's other things that you need to work on. I think that is so important to validate the interventions that you're applying and making sure that you're going about this in the correct manner.
Yeah. And maybe like if you are like, let's say you're like doing a kind of intervention that, you're, or let's just take a clinician who's not maybe utilizing test retest as much, or, they have a patient who's, just generally having transient small reductions in symptoms over time. Maybe the long-term outcome between that clinician and how we would address it is similar. Maybe we would get a better short-term outcome. But I think there's certainly like merit to, having a better short-term outcome, and then having the person understand, why it's improving, rather than you're just generally applying multiple different kinds of interventions, and then it's just steadily, gradually reducing over time. So yeah, like you said, getting down to, okay, what's the root? What's producing this range of motion limitation? What's producing these symptoms? Figuring it out so you and the patient are on the same page, and you know what it's going to take to address those symptoms and help the patient reach their goals. So
now, one of the things that you talked about, and I think that we'll probably agree on this, is you mentioned like improving their tolerance to like specific activities or their capacity, and reconditioning their that specific joint or the musculature that's involved.
Right.
What exactly does that look like for you? Are you working them through like a pain-free range or task? Or are you expecting them to have some symptoms, or like when do you start to incorporate that compared to like all the other interventions that you're looking to apply?
Yeah. So let's take the, for me, my first line approach, repeated movements. If you said, I'll give it 2-3 visits. If we're not getting that, like, that real home run response, that rapid lasting change, if we're not seeing any kind of, if it's just not sticking, okay, I'm starting to look elsewhere. So I feel like, a couple visits, all right, we're kind of topped off there. Then we can look at, different movement, or like, do we have to go more of like a motor controller? Do we have to, just work on moving slightly differently so that, they're not symptomatic in a certain task? We'll go that route. If I've gone through there and we're not getting like a consistent lasting reduction in symptoms, then we're looking at this exposure reconditioning route. So what that looks like for me is, this is a patient who, typically has pain when they perform certain movements, certain activities, for whether it has to do with the volume of the activity, with the duration, or perhaps like the load. So, but they don't have, if they reduce or eliminate the irritating factor, their symptoms aren't remaining worse afterwards. Okay. That just, once we've exhausted the first two treatment methods, it seems like you're left over with this kind of presentation. Now, it certainly varies, but this is just what seems like this kind of presentation is left over, right? So symptoms are produced and can become worse with continued use. They typically don't remain worse afterwards. So, at least what I found to seem to work in my approach is, picking a couple exercises that are producing those symptoms, okay, having them perform those exercises to the point where pain's being produced. If they worsen within the set that they're completing the exercises, that's okay. I usually try and quantify it. Maybe we're not going more than like a 5 or 6 out of 10, just so the patient gets an idea of where they should be working. Okay. And the symptoms should calm down to whatever their baseline symptoms are within, we'll say, 1, maybe the max 2 minutes. Okay. Now, we have a little bit of leeway when it comes to those specific guidelines. I'm quantifying it now just to give people an idea of, what range they could be working in. As a person's improving, let's say they're 95% better, you're probably not going to be getting to that 5 to 6 point. You're expecting their symptoms to begin to resolve at that point. But yeah, I think the reconditioning exposure type program that I usually implement is, a couple exercises that are performed anywhere from 1 to 3, maybe more times a day, a couple sets to the point of, producing pain. And it may last a little bit, but not too long. And it shouldn't get so bad you have to stop doing the exercise. And there's not specific exercises I look at. It's just, we're using our background knowledge from about anatomy and structure just to target that area. Like let's say it's like posterior lateral shoulder pain, right? It's worse reaching overhead, reaching to the side. Okay. I went through my evaluation. They're symptomatic into forward flexion, abduction, ER. Okay, here's your band. You're going to put it under your foot. You're going to raise it forward. Okay, ask them, you gauge a symptomatic response there. Okay, let's move it to the side, gauge it there, and then tie it to a doorknob and, move your hand outward while you're, do some resisted external rotation. It can be simple, right? But again, in this case, we're probably not we've exhausted our avenues in terms of getting a rapid lasting reduction in symptoms. This is more of a medium term response. So we still retest, but the specific exercise doesn't have to be anything special. It's just about operating under the guidelines of the symptomatic response that I described earlier in regards to pain and the duration of pain.
Got it. Okay, so that's really interesting. So when you say improving and reconditioning, their tolerance to activities and stuff like that, it's more or less like getting their body used to their pain and then kind of acknowledging it, working within a range that's acceptable for them. And as they continue to improve, that pain starts to decrease. And I assume it's just like it's that you've made that change where their nervous system kind of accepts those levels of pain and acknowledges that it's no longer inherently like dangerous or harmful for them to perform. But that's acceptable.
Sure. Yeah, and this is derived from the kind of literature I've read on, like when it comes to chronic tendinopathy, when there's a paper I can think about specifically that talked about just generally pain during exercise from a rehab setting, and a little bit from like the MDT classes I've taken. But yeah, I don't know if I can tie it to like one specific certain mechanism, but it just seems to be if you have specific direct input to the structures that you hypothesize are producing symptoms, if you have people work within a certain range, then over time it seems to improve, right? Even though they're having symptoms with specific tasks and things like that, the kind of input you're getting when you prescribe the exercises are just it's different. It's more targeted, right?
Sure. Is there a time or is there a situation where you wouldn't look to do that, where you wouldn't look to treat it in that manner? I know that you mentioned tendinopathy and that one definitely makes sense, but are there other ones that you would not typically utilize that method of treatment for?
Or I mean, I think you said tendinopathy. There are like, I mean, cases of tendinopathy that I think, especially if it's a real chronic thing, I think there can be value into poking into symptoms initially. But yes, like certain cases where I wouldn't do it, and it's all, test retest, symptomatic response. If someone is, let's take the posterior lateral shoulder pain again. Someone's coming in and, they got real low strength, and I'm going to like back to like a real baseline early movement, like supine cane flexion, and they do a couple reps and they're shooting up to an 8 or 9, and they can't even do the full range. All right, we got to scale back. We might have to go back a couple steps. Like, I don't know, maybe we go to something without joint movement. Maybe we go to isometrics. Maybe we just have to like really get these symptoms under control in a different way before we approach it from a movement standpoint. I'm trying to think of any kind of like, quote unquote, appropriate for PT patients where I wouldn't do that specific thing. Maybe someone who had variable symptomatic response to movement, that, sometimes they come in and they have no pain. Sometimes they come in and they have a lot of pain. Maybe I'm trying to do more total exercise to tease things out and have them reassess. Yeah, I can't think of like any specific good presentation. I just think like the other two things I talked about, the repeated movements and the other kind of, not repeated movements, but different kinds of movements to help the patient reduce them. I think, you kind of cover most of your bases when you go through those three things. So yeah, I'm not, Kane, I don't have a good answer for you. Sorry.
I was thinking like a highly irritable rotator cuff.
Yeah, okay,
is
so
probably one of the ones that I would not do that for.
Yeah, that's what I'm thinking for like I said, yeah, like I mean if they can't even do like a lowest level thing, I can think of like a supine cane flexion. Like I don't know how much, or like pulleys, you know what I mean? I don't know how much they're gonna tolerate like repeatedly loading that structure to remodel those tissues, or to like, I don't know if the exposure reconditioning program is going to go well for them. When they're then that symptomatic, right? Yeah.
Yeah, when they're that irritable, I've definitely had a couple of shoulders, and I usually try to modulate their symptoms as best as we can. Like I will take them through ranges of motion, passive, active, assistive, whatever we can do. I'll check to see what the response is to isometrics. I just want to get those joints and those muscles moving as best as we can and as they can tolerate. But there are some times where like a rotator cuff is just like they need the surgery. It's as simple as that. Like they're just too symptomatic, and that usually occurs if they are a traumatic tear. It's usually not the case if it's like an insidious or a chronic rotator cuff issue. But those patients, I would say, are a little bit tougher, but in the sense of like, okay, how much time do we give this? But I think that they end up being easier because they're so symptomatic that you have your answer pretty quickly. Like they're really irritable. We are not making any changes here. And I've had a couple of those patients where I would give them like 1 or 2 sessions. And honestly, by the time that the next session even comes, they are back in seeing the ortho, and they're already booked for an MRI and for surgery. And that just makes my life a lot easier. But it also just tells me that, hey, they're way too symptomatic. Like they need another intervention because I can't make any of those changes.
Yeah, exactly. Yeah. So why don't you tell us a bit about you're using the term motor control, and I think like I'm using the term I think we'll talk about motor control specifically in a different episode. I'm using the term after repeated movements. So you're looking to change their symptoms with different kind of movements. That's not necessarily repeated. I think we're talking about a similar kind of intervention. But what is it? What are you looking to do from a motor control standpoint? Are you looking for a quick response? Is this more of like a longer term type thing? How does your approach look like there?
It definitely can vary. I've noticed that a lot of times when I improve motor control, and
what do you mean? What do you mean by yeah? Okay, sorry.
Yeah, what I mean by motor control is their quality of their motion. So I'm looking to see if things are moving like if there's like any aberrant motions that really stick out to me where I'm like, okay, that does not look like an efficient
Oh,
pattern.
okay,
And
efficiency. So maybe something they're doing something they're not aware of, and they're symptomatic because of it, and that's
yeah.
okay. Okay.
Yeah, so and I don't say that as someone who's like rigid in how
Yeah.
someone should move.
Sure.
I think
Sure.
people should move how they're kind of born to move in a
Mhm.
way. But at the same time, if you came in with pain because you've been moving a certain way, you're probably not moving it in the best manner versus someone who actually is meant to move in that way. They don't have any issues. I'm probably not going to correct that. Like, I think a really, really good example of this is when someone squats, right? Like, a lot of times, people will give a lot of flack to people who squat and they have knee valgus. But if you look at some of the top squatters, they will still have knee valgus when they
Yeah.
do it, and they don't have any pain. They don't have any issues. Who am I to change them? Because like that's their performance. They can
Yeah,
squat a whole
and
lot
they're
more than me.
performing well, clearly, right?
Yeah. So
Okay.
it's just like improving their quality of motion and maybe their muscle recruitment in when they're having these issues. And if we can make that change, that kind of tells us a little bit more. And I'm not someone who's going to force feed that where it's like, okay, sometimes I address their movement quality and it gets worse. And I'm like, okay,
Mhm.
so that's just
Yeah.
not the right thing for you.
Right.
So it
Okay.
definitely like it's not something I use like that I try to squeeze everyone
Yeah.
into
Yeah.
this pigeonhole, but instead I just utilize it and see, okay, can we make a change here? It's the same thing with all the other interventions that we've talked about previously, where you test and you retest. If it makes it better, awesome. You just found yourself a new piece
Okay.
of information that's useful. And if it doesn't, it tells you, okay, maybe this isn't the right thing, or maybe it's not the right thing at this current moment in time.
Yeah.
But how I kind of go about things is let's say for example we've used shoulder a bunch, so I'll
Yeah,
go
yeah.
on to like knee pain for example. But traditionally from my understanding, a lot of people when they have knee pain, they will usually just go in and address the quad. They will just work on the quad over and over and over again to improve their strength, their power production, and things along the lines of that, which I think is an okay place to start. But in my experience, what I've seen works super well when the repeated motions or mobility isn't really giving them the merits that we want is addressing their hip and addressing how it's moving and how it's functioning when they're actually doing their different patterns that they do in their normal day to day. So one of the things that I go to right away is I will check to see how they do on a lateral step down, how they look when they're squatting. I love the step down because it's a single legged movement. You still have stability from the handrail, but we can really see where are they compensating with? Are they rotating their trunk? Do they drop at their hip? How's their knee tracking? And any of these things? Is it excessively forward? Is it moving inwards too much? Is it moving outwards? And all these different things. And if it reproduces their pain, that gives me a lot more information. And so one of the things that I immediately go to is when they have this issue, can I fix it with just cueing? Can I tell them to push your hips back like you're reaching for a chair so that way they actually recruit their glutes a little bit more? Is that going to change their symptoms? Sometimes yes, actually a lot of times yes, and other times less so, and that's okay.
Yeah.
And then the next step that I usually will go to is I will usually use a Captain Morgan. It's one of my favorite exercises for knee or hip issues. But it's essentially an isometric that you're performing at the wall, where you're pushing your shoulder into the wall with the outside leg, and the inside leg, you're also pushing into the wall. So it's like you're spreading the floor apart. And I'll usually give them a ball so that they have to perform a march. At this point, you're just learning how to move your hip again while simultaneously contracting your glutes. And in doing so, this just gets those muscles to, I don't want to say kick back on or wake up or anything like that, but it just teaches you how to recruit them in a functional pattern or in conjunction with other things. So then I'll retest it again with a step down, and usually you get better results that way.
Yeah. So like you talked about, maybe, that's just like regarding terminology, it's not like you talked about, like they're doing the movement and then you're retesting the quote unquote problematic or symptomatic movement afterwards. Hey, it doesn't matter if, we're not saying that, the glutes weren't, doing their job before, they weren't like activating, they weren't firing, they weren't working, but hey, retest, we picked a movement, we had them utilize the muscles they think would, benefit or make their movement more efficient, or in this case, less symptomatic, and it worked. And you're continually reassessing, going back and forth. So you're not necessarily saying, like you talked about, okay, this is the way you have to move. You're just using your knowledge to see how they're moving, hypothesize what could potentially be leading to the symptomatic response, applying an intervention within the, within this realm to see if it has an effect on that movement.
Yeah, I think there's this like idea where there's ideal movement, and I can't stand that actually, because and I have previous experience as a strength coach, and that was like the camp that a lot of people fell into previously. And to me, I just don't understand training that, because it just limits people into only being able to do one version of that motion, and any deviation from it becomes less efficient for them.
And you limit your treatment too, like from the clinician standpoint. It's like, oh, this is the way you do it when you're gonna miss a lot. Yeah, it's not for everyone, like you said.
Yeah, so I feel like a lot of times when we do that, it's like micromanaging the patient of how they're supposed to move. They're just going to constantly be thinking of, oh, am I squatting down right? Oh, am I deadlifting this right? Like, I need to like do X, Y, and Z before I bend over to pick up a piece of paper.
Yeah.
And that just strips away so much of what life is for them. I don't want them to think about that. That's not how it should be, right? But instead, we should think about like these motions as a norm. There are like there's a range of it. Like you can move through that norm and be totally okay. Some people are right in the middle. They have textbook picture perfect form when it comes to these motions, and that's fine. That's their like, that's how they were born. They can do that. They have the leverages to do that. Other people don't look like that at all. And that's totally okay. You just have to be able to work with a patient's like individual anthropometry to make sure that they are doing things that are right for them. And that's something I really try to get across to all my patients.
Yeah, like you said, just for that specific patient, how they're moving, like, right for them, like you said. So what about, let's stick with this topic then. Like, what about someone who, let's just take knee again, because you talked about quad. How about someone who has pain with resisted knee extension and pain when they go up and down stairs, and it's located kind of like anterior knee type thing? What do you, if they have pain with resisted knee extension and they're not able to produce the amount of force to, if they have pain with resistant knee extension, you're testing it from MMT standpoint. You're able to break them. They're not able to produce enough force when you're testing them like that. We could say, quote unquote, there's a strength deficit. How are you addressing that?
So is it truly a strength deficit or no? And I think that this is where our common ground with repeated motions is really, really helpful, because when something's in pain, you're not, it's not that you have a strength deficit,
Yeah.
you're inhibited now. So
Yeah, yeah.
there's definitely a big distinction that needs to be made for an inhibition of a joint and the
Certainly,
muscles
yeah.
around
So we
it.
can break
Right.
that
So
down a little bit too, like you talked about. What's causing the MMT not to be, this number? Why? Yeah.
yeah, so if someone has such a profound weakness like that, one of the first, and given that they don't have any other red flags
Right,
or
right.
anything like neurological going on, my first thought process is it's got to be the joint. Like nothing else really causes that, because if you address the joint and then, like, say you go through your repeated motions for the knee, that should clear, or at least help to clear some of that up.
Yeah,
And
yeah.
if you're getting nothing out of that, I would honestly be pretty surprised. If you're going through it and you get some changes or it fully resolves, that to me, I wouldn't be surprised at all based on that presentation.
Based on that, yeah.
But the other thing that I usually will try to do is, if we're getting results there, I still want to make sure that their knee is actually functioning how it should be functioning. So from there, if we're getting some results or nothing at all, I want to see what happens when we have them work into an isometric. I'm going to change the different ranges of their, like the angles of the isometric, and see, okay, where are you more symptomatic and where are you less symptomatic? Let's work there and see if anything changes.
Yeah.
Because sometimes that tendon just needs to be loaded. Now, when you say anterior knee pain, to me, that could be like around your patella. It could be at your patellar tendon. It could be at joint line. It could be any of those things. So that's where I think it's really important to make sure that when we tease out that information, we're addressing the correct cause. And the curveball here, I think, is if they have pain that's like pinpoint at their patella or at their patellar tendon, for example, and we're having that profound weakness, and it's not necessarily like strong. It's not strong and painful. It's just weak, or it's weak and painful. I think one of the things that we can't forget to investigate here is their spine as well too. That can definitely be a problem here. And I think that is so overlooked when someone's like, oh, my pain is right at my patellar tendon. It's like, okay, it may or may not be coming from that area, and that's fine.
Yeah, same like you, or sometimes my knee gives out. I don't have any pain. It's kind of weird, right?
Sure. I think that when we are able to at least narrow down some of these parts, it makes it a whole lot easier for us to really know, like, okay, where should we treat? Where do we go from here? And so I know that we're really big on the test retest, right? And we talk about standardizing things and how we kind of go about that. And we even mentioned it in the beginning, where it's like, oh, we usually go for repeated motions first, and then we restore range of motion, and then we go motor control, and then we do all these other things, right? But I was going to ask you, how do you go about addressing or incorporating multiple things at once? When do you start to do that? Or do you just only stick with one impairment at a time?
So I find typically, at least in the patient population I see, is that they're coming because of pain. So if I'm doing repeated movements and it's reducing their pain, and we get to the point where their pain's eliminated just doing repeated movements, at that point, my job's typically done. Right now, let's move the spine. Let's say, they are a patient that had their directional preference, the movement that they had the best amount of pain reduction with were extension based movements. It's not to say that they're only doing that, and then once their pain's gone, they're being discharged. They will flex at some point. At least in my practice, they're going to flex under load at some point. So I know, like you talked about, I don't want them second guessing themselves or having in the back of their mind all the time, oh, if I bend over, I got to do it this way and do like this. No, their spine should be able to move through range under load how they want it to. So yeah, I mean, I'm essentially, addressing their primary concern, which typically, said in the patient population that I see, is pain. If let's say it's been 4, 5, 6 visits, repeated movements, I'm only getting like 50% of the way there. Their pain's decreased. That's enough for me to say, all right, it's been enough time where we've continued to do this type of intervention for a certain amount of time. We need to move on. So then I'm going to start to look at different movements, or maybe control aspect when it comes to a certain provocative movement that they're doing. If we're still not getting the desired response after a couple weeks of that, all right, then it's more the conditioning exercise component. Maybe we're looking at other factors that are contributing to the symptoms. Maybe it's not something orthopedic or physically related. So yeah, the repeated movements, I think, should have the most rapid response. So if it's been a couple weeks, or let's say 5, 6 visits, and it's just not getting, if I don't see symptomatic improvement to the point where I think that's going to be the 100% answer for them, then I'm starting to move on. And then, where we go from there is just, there's a little bit more to talk about in that regard. But yeah, it's usually those last two things may take more time when we talk about the reconditioning and the control aspect.
Got it.
Sometimes I guess I don't, just because I try to standardize as best as I can. I try not to get too many things going at once, especially like I said, if repeated movements, to me, if I feel like that's going to be the answer for them, I don't, we're doing that single movement. I don't know, if let's say, we can move back to extremities. Let's say it's, shoulder, repeated movement thing, they're doing repeated internal rotation behind the back. My gut and my previous experience, once, it's shoulder pain, they got to be doing TheraBand, external rotation, Scaption, blah, blah. But if we're getting the desired response out of a single approach, I don't see a reason to start to add other things.
Sure. And I definitely, I agree with that to an extent. I think especially early on when you're trying to narrow things down and figure it out, I think that is it's super helpful to standardize that. I think one of the things that in regards to doing that, though, is if we stay consistent with that, is we can slow down the amount of progress that we can actually make for our patients. So I think that being systematic is great, but as you start to get more and more comfortable, as their symptoms start to reduce and their irritability, their levels of irritability have improved, I think that's where we can start to really identify certain things where okay, these are some of the lingering deficits that we can work on, and we can work on it in conjunction. It's not like we can only do one thing and that needs to be completely resolved before we move on to the next. Yeah. For example, for a shoulder, if we do a repeated shoulder extension and that helps to resolve their issues initially, that's awesome. Well, I'm going to stick with that and I want to see if it continues to help. But then if I notice, okay, now it's calming down, that's awesome. We've made that big change, but there's still a couple of things that are lingering. That's where it's okay, I'm going to stick with that. And then now I'm still going to add in more stuff. Do I need to work on their motor control? Do I need to recondition them in regards to their activity tolerance? Are they comfortable doing those things? And are they fearful of it? If they aren't, that's awesome. That's just going to make your job so much easier. But when you can incorporate all those deficits, that is going to make it a lot easier for you to make progress for your patients in a much more succinct manner.
Yeah. Yeah, yeah, I agree. I mean, I definitely do at some point combine things. Like, let's say, like I said, let's say we're taking the repeated movement approach. We're at visit 5, 6, and we're 50% of the way there. It doesn't mean I'm not stopping repeated movements. Like, okay, hey, we know this has gotten you to this far. Maybe you don't have to stop it, but we're going to throw in, yeah, this certain tendon, this tissue, excuse me, this muscle seems to be a bit irritated. Here, let's start to do some exercise for that. Even though it's improving to some degree, with a different methodology. Yeah, I mean, maybe the combination, um, at some point, if we're not getting the response we're looking for over time, yeah, I think, combining them has some merit. I just like,
Yeah,
I
sure.
guess the only time like I don't combine or don't see a reason to have to combine is if, let's say we're at like visit 2 or 3 and they're like, yeah, I'm like 90% better. It's been like a week and a half and, they've had pain for 2 years and they're 90% better. Like, you know, all right, that person's going home. They're doing the same thing. I don't see, you know, a reason to have to, add some more variables to it. Now, it's different if they're 90% better and they're like, hey, I want to get back to the gym and stuff like that. Okay, cool. Yeah, we're gonna start. Let's start loading it up. Let's do that. So we can contextualize it farther and say that if we want to work, if the patient has specific goals, that I'm not gonna tell that person, oh no, not yet. We have to ride this out until you're ready, right?
Sure, sure. And, one of the things I actually wanted to bring up before I forget,
Hmm.
is like when you talked about reconditioning or like improving activity tolerance. This is something that I started utilizing a lot more recently, and it's the concept, and this I got from like working with people who have chronic pain issues and stuff like that, especially for like low back pain. Is I started using a lot more aerobic exercise
Yeah,
for them,
yeah.
and just getting them up and moving and seeing how they feel afterwards, and just
Hmm.
gradually increasing their aerobic capacity. Because we know that helps with circulation. We know that it helps to desensitize you in regards to like your stressors and your pain levels and stuff like that. So I started to actually do a lot of the same things for other body parts. Like if it's a rotator cuff, for example, I'm going to give you something that's light and that isn't going to provoke symptoms. I want plenty of blood flow. You're going at it. Like you're going to get a pump
Yeah, yeah, yeah.
in that muscle. So that is exactly what I want. And it helps to desensitize it, and it makes the rest of your treatment session a lot easier for them to get through. They may be tired and fatigued, but they're not really having symptoms after that from what I've noticed. Is that something that you've implemented in your practice at all or anything like that?
Yeah, yeah. I mean, that is, I think, falls into that second category when we're talking. Like, if you said they have a positive symptomatic response after something, like, hey, yeah, like I noticed if I work this area to a certain degree, like, I it starts to feel better, right? And whether the exact mechanism, who knows, right? We just know that they have a positive symptom. They have a positive response to that certain movement. Right? Like, yeah, we're gonna keep doing it. Yeah, here, oh, actually, it doesn't feel. Maybe over time they need more resistance, they need more load for it to keep getting that response. Sure, yeah, no, we're gonna keep working and we're gonna keep progressing them. Um, whether it comes to sets, reps, whether it comes to resistance, frequency, right? It's just trying to figuring out what's working and figuring out a way to facilitate the continued improvement. Okay, anything
So
else you want? Yeah, go ahead.
I was just gonna say, so we covered a whole lot of
Yeah.
different things in regards to like the different categories of treatments that we would typically apply for our patients, and how we would go about addressing each of the deficits that we've identified. I think this gives us a really, really good like base of how we should be approaching different presentations, and that gives us like different options to know how to pivot and what exactly we can do when a certain treatment method isn't going the way that we initially planned. And for next episode, I think it's going to be fantastic for us to really dive into a little bit more about how we can create more progress, like how we can look to advance and progress our exercises for our patients and making them more relevant because physical therapists are known for chronically underloading their patients.
Just
And
having
this
people
is
go
where
through
I
the
think that
motions. Yeah.
yeah, and I think that this is super important because like we want to make sure that we're actually stressing the tissue, the joint. That
Yeah.
way we
Yeah.
know what we're getting. Like if we're underloading, we're not going to get very good answers.
Yeah.
So I think that being able to see what our patients are capable of, showing them that they're capable of doing so much more is going to be really, really cool to see. And I think that's going to tie in really well. So like we can see like how exactly we're progressing them, how we're getting them ready for discharge, and then how we're able to kind of help prevent a recurrence of their symptoms as well too.
Yeah. Absolutely.
All
Yeah.
right. Anything
So
else that you want to add, Mark?
just to summarize, it seems like Kane and I are our first line of treatment. What we look to change symptoms is through repeated movements. We do for spine and extremity. The next thing is that we look to gain a symptomatic response from, if we've exhausted repeated movements or in some cases combined, is our, as Kane puts it, motor control. I mean, we're going to have an episode on this, but the term, I don't tend to use it too much, but I'll use different kinds of movements that aren't repeated movements. Kane uses motor control. And then our next line is that we're looking at the reconditioning, activity tolerance, and exposure approach to helping patients. All right. Well, thank you for listening, everyone. And we hope you enjoyed this episode of the PT Good podcast. Remember to leave us a like and subscribe to us on whichever platform you're listening to us on. And we'll see you on the next episode.
Missy, love you. Bye.